Thank you very much, Una, and thank you very much for inviting me. I'm really happy to talk about this work that I'm doing. And just really, like Austin, just to give a brief overview, I'd just like to talk about in the context of this particular STAP project, but also data linkage projects I've been involved in, because I also believe we're really going nowhere if we don't have data linkage. And I'd just like to talk, I suppose, a little bit of reflections on the positives. I think things I feel have improved from my experience, and certainly challenges from a researcher perspective, and the need for data linkage. So just to give you a brief overview of the current STAP that I have, this was actually identified as a priority by the Department of Health, and also the European Commission see it as a priority. We know a lot about opioid dependency, but we know much less about the misuse of prescription opioids. A lot of information is coming from the US, but obviously our regulation and our system is quite different. So in this particular project, I, with others obviously, I'm really interested in looking at the supply, and lots of us always go to the PCRS and we look at how much is prescribed to patients with GMS cards. But also, given that we're talking about misuse of prescription drugs, particularly I'm talking about opioids, benzodiazepines, gabapentinoids, and Z drugs. I was also really interested in looking at Irish prisons, because we know that there's a lot of misuse of drugs there and a lot of diversion, so it's a really important cohort and group to look at. And of course then, because we're talking about misuse, we're interested in looking at seizure data from law enforcement. So of course, looking at this and the supply is obviously not going to capture polydrug use, because we're just seeing what's prescribed or what's dispensed to people, and it certainly doesn't capture the actual illicit use. Even if we're looking at illicit drug seizures, it's not really telling us what people are taking. So the other part of the project is to look at detection rates. So this was sort of a novel area for me, and this is linking in with a lot of laboratory groups. So the Medical Bureau of Road Safety, so looking at people who've been under Road Traffic Act, who've been stopped, and there's been drug testing. So we want to look at the level of detection of these particular substances concurrently and alone, and concurrent with illicit substances. We're also working with the state laboratory, so we're looking at all post-mortem toxicology, so not just for those that are drug poisoning deaths, but we're looking at the detection rates of these substances in post-mortem toxicology results. And then the National Drug Treatment Centre. So one of the areas of interest is, of course, new psychoactive substances. So obviously people who are using opioids often are the first group to use multiple other substances. So it's really important to look at that cohort and see, because often that's where a lot of these new substances are first detected. And then, this is giving us a lot of information, particularly in subpopulations, but again, it's not really quantifying the harm. So if we really want to look at the actual burden of harms, we're then looking at epidemiological indicators. So, and this is, I've worked a lot with Sarah, so getting data from the HRB, so the National Drug-Related Death Index, and getting information on drug treatment demand, so the National Treatment Reporting System. And also working with Professor Ella Arensman and Paul Corcoran down in UCC, so information on national fatal intentional drug overdose. So it's a lot of data sets. And I suppose my experience from working on this and previous projects, I think the positives are that there's definitely more of a desire to optimize the use of health and social data sets. Certainly my previous experience when I first started doing my postdoc with Susan Smith and Tom Fahey, I remember being in meetings and exactly as you say, Austin, people saying, no, you can't have the data, you'll never get that data, it won't happen. And with time it does, albeit very slow. I think we can see the fact that there are these STAP awards, it demonstrates that there is a desire for this, and indeed the Department of Health called for this particular project to be done. And we know also at a European level, there's a real interest that we need to understand more about drug trends, but it needs to be real-time data, exactly as Austin has commented. And we need to strengthen our national drug monitoring systems and our capacity. So for me, what's been really positive in this project and previous investigator-led project that I've had is I think the idea of working with knowledge users is really good. My original background has been in health psychology, and then I moved sort of more into epidemiology, and sometimes I have a sort of an identity crisis of what I actually am. But working with knowledge users, and I've been really lucky, I work with Professor Eamon Keenan, HSE National Social Inclusion Office, and it's been really good, and it's been really helpful in terms of the research having an impact and really having that clinical input has been really important. And also working with somebody who's really interested in the area, because obviously then there's time for meetings, to review, to discuss things. So I think that's been really helpful. And also familiarity with current policy, but the nuance of the policy. I mean, we can all read policy documents, but really understanding where the pinch points are. And that ability to affect policy change is really important. So, you know, working with people who are linked in with the Department of Health, who can, you know, talk to them and discuss the findings. So that's really important. And also working as a team where you support PPI, where you have that patient perspective as well. To the challenges, and these slides are a little bit longer. I think particularly when we're talking about secondary data analysis, you know, I think there is still a little bit of a culture of caution. And first of all, you have to identify the data set. So I'm sort of repeating what Austin has just said, you know, who is the data controller, where is the data? And from my experience, it's great, you know, working with data controllers, but often within that system, you need to find somebody who actually uses the data, because the data controller may not really know what their data is. So it's engaging with somebody who uses the database or the software system on a regular basis. That's really helpful, because they know exactly what's there. And I mean, that is what I really mean by when I talk about opening Pandora's box, because, you know, you have meetings and it's like, yeah, we definitely have that data, that's great, and you go home happy and it's all great. And then they tell you it's electronic, and that's fine, but then maybe they've scanned PDFs, which is not electronic, you can't extract that. But also it's understanding why they're recording the data. So what is their remit? They all have different remits, so we have to understand what that is. Can it be extracted easily? Can they find the data? So, you know, sometimes again, if you're talking about a 10-year observation period, the data may be in different software systems, and then there might be a 6-month period where nobody knows where the data is for that. So, you know, that can be difficult. And if there are those changes over time, maybe, you know, drug testing, and in my case, different policies, different practices, that's obviously inevitable, but, you know, that's potentially going to introduce bias into any definitions you may be using in your studies. Data dictionaries will not always be available, /never. Consistencies across the data set. Again, you know, in terms of this project, we're really interested in looking at gender differences, age differences. And while they may record age and gender in the paper form, it may not then go into their electronic data set. And if you're talking about thousands of cases, you know, they're not going to be able to enter it for your particular project. And surprises are inevitable. And of course, then you also need to have your data sharing agreement signed, and you do all of this right before you submit your grant application. So that's a challenge. And I think with this particular project, like, there are a lot of data sets, but we managed to get all these signed because we had worked with many of them before. So there was, as Molly said, there was that sort of trusted relationship. And I think that's really important for this sort of work. So you can concentrate on those that you haven't already got access to. So I think also in terms of challenges, I think it's really important that we do target and try to get administrative data. You know, it's this data produced by services as a byproduct of their day-to-day activity. They're not collecting it for research purposes. If we think of dispensing records for medications, let's say, the PCRS, for example, there can be delays in accessing the data. So they have competing demands, so they agree to give you the data, and then, you know, you're chasing up and you're chasing up, can I have the data, can I have the data? So that can be quite challenging. And also, to be fair to the data controller, the onus is on them to anonymize the data before they give it to you. So they can be quite concerned about that, and that can delay things. So that is definitely a challenge. And when we're using these data sets, you know, how we define exposures or our observation period is completely determined by the quality of the data set. And so we need to have a sense of that before we actually can do anything. So it is a challenge if you don't know the data set when you're applying for the funding, if you don't have a good detailed knowledge of it. And what are they willing to give you in terms of anonymized data? Are they willing to give you aggregate data, which isn't really what you want, or are they going to give you, you know, anonymized individual level data, which is what I would always ask for and hope for, but sometimes, you know, you get the aggregate data. And I think we talked a little bit about capacity. I think this is a real issue for these type of grants. Generally, you need a really strong biostatistician, like a postdoc who's really strong in biostats, who can really, you know, work with this data. It can be quite complex data analysis. And it's harder and harder to find because a lot are moving to industry because of salaries and short-term contracts. So right now I'm really lucky. I work with an amazing biostatistician. So I do think we have work to do in terms of capacity development. But sort of hot on the heels of Austin's talk, I actually think the greatest threat of all is that because we're not doing data linkage, we have this over-reliance on ecological analysis. And while I think this SDAP project is really important, but for a lot of the analysis, it will be ecological, and particularly where we've anonymized aggregate data. So we can see there's an increase, let's say, in prescribing of particular drugs, and then we see that that same drug, there's an increase in its identification in drug poisoning deaths, but we don't know if the person who has the drug poisoning death actually was prescribed the drug. Whereas if we could follow individuals, we would be able to say something more clearly about that. So I think we do need to have infrastructure for data linkage. We definitely need a unique health identifier. We should be able to know what data sets are available. It should be fair administrative data. Record linkage across sectors, so again, social, structural determinants of health, and particularly, so the area that I work in particularly with drug users, very often this patient group, they may not appear in a lot of primary data sets. So really you will find them in administrative data sets, but they're not sitting at home waiting for a telephone interviews sort of project. So we really need a third-party data processor, safe haven model, and this is something that I have worked on before. So the first project I worked on with this was when I was in the HRB Centre, and then subsequently I got an investigator-led project looking at opioid dependency and particularly opioid agonist treatment. And this is where, working with different data controllers, we got data from prescribing data, and also the National Treatment Register for people on methadone, so it's called the Central Treatment List. The great thing is they actually have a unique identifier, so they have to have one. So that was great. So we could link that to prescription data, so we could get the PCRS data. We linked it to GMS data, so we could get co-prescriptions, and also linking to specialist addiction clinics, because people can be prescribed their methadone or buprenorphine in different settings. And then we were really interested in identifying periods of high risk for mortality. So it was again linked to Sarah's data set, the National Drug-Related Death Index. And really, we got the data. It was identifiable. We didn't get it in the RCSI. What we had was an agreement with the CSO. So the data went from the data controllers, identifiable data, to the CSO, and then the data was processed there. It was linked there, and then it was anonymized, and we received the anonymized data, and that allowed us to analyze it and interrogate and look for periods of high risk. And I think just very briefly, just one point on that is one of the things that we identified across a number of papers, and there's also a Scottish study here because we followed that model in terms of data linkage, is we identified periods of high risk, and particularly when people leave treatment in the first couple of weeks, there's a really, really elevated risk of mortality. And this, from our work, there was an editorial in Addiction which commented that we need more of these types of studies, not only in Ireland, but we need them certainly in Ireland too. But really the idea is we need to have stratified medicine for treatment of opioid dependence, and also so we can pool experiences across different healthcare systems and different countries, so we can see where things are different, where they're the same, where certain interventions are taking place. And ultimately, so we can ensure that we have the right patient gets the right treatment at the right time. And I think we did that, and this is part of a global meta-analysis, which again pooled all the studies, including our Irish work, and identified across the board that we're seeing the same pattern. There are these high-risk periods. And then came COVID, and again, working with the knowledge user and working closely with Eamon, who's heavily involved in developing treatment guidelines. This information was then used because then COVID came, and there was a real concern about people with opioid dependency, and because obviously there's a high risk of mortality anyway. And this information was really used to guide the clinical guidelines, or these contingency guidelines, because one of the biggest concerns was, well, if we know that there's a high risk when they leave treatment, this is a period of time when they may not be in treatment, and there was a real concern that there was going to be an increased risk of dropping out and indeed mortality. So I think it's evidence of how data linkage in the Irish context did inform really important policy and clinical guidelines to try to reduce mortality. And there was a very low mortality rate among people with opioid dependency during COVID, so it was positive. And just to finish, obviously, this work wasn't all done by me, so this is part of a really interdisciplinary, multidisciplinary team with lots of different partners from different places. So thank you.